In regards to maintenance-based therapy, lenalidomide has really changed the way we do maintenance. We now have 3 large randomized trials that show a benefit in terms of progression-free survival in patients taking lenalidomide versus not taking maintenance-based therapy. And when a meta-analysis of this data was performed, again, there was a marked advantage in terms of progression-free survival, but also in the meta-analysis, there was an advantage of overall survival. And those that received maintenance, in fact, had an overall survival advantage of over 2 years. It was more like 2.5 years. And for me, that's really telling that lenalidomide has become our standard therapy for maintenance-based therapy, especially after transplant. There is data also for lenalidomide as maintenance after primary therapy for those patients that don't undergo transplant. Now, there's caveats to maintenance therapy, and we might treat high-risk patients a little bit different, but certainly lenalidomide is the mainstay of maintenance.
One of the important questions about maintenance is, what is maintenance and how long should maintenance be for? And I think that's a really important question. So at disease relapse, you should clearly continue maintenance if you can until the next progression. I think that's where the data is. Up front, for newly diagnosed patients, we've just completed a study and we tried to continue until disease progression. But actually, when you look at that study, only 30% of patients were on it for beyond 3 years. So really, there's a thing about quality of life which impacts on how long you can actually deliver maintenance. And so for us, we continue maintenance for 3 years. The French, arguably 1 to 2 years, and a variety of physicians use different timing. But at one level, it all comes down to the same thing, that it's hard to stay on for more than 3 to 4 years. And so you're driven by the patient experience and toxicity.
So if you have a patient that has undergone therapy and is now in complete remission and is receiving lenalidomide as maintenance-based therapy, you're really following them closely for side effects. Patients on maintenance have upwards of a 50% chance of having some cytopenias, either neutropenia or thrombocytopenia, and some other potentially quality of life side effects like fatigue and diarrhea. Patients that have achieved a really good response, like a complete remission, and have some side effects, I have often taken those patients off maintenance-based therapy. My personal approach is in a patient like that is I take them off for 3 months. And after 3 months of being off maintenance, we revisit the issue. And we say, okay, how was that 3 months versus when you're on maintenance? If your quality of life is really so much better, then we probably should continue off maintenance. However, if there's really not much change in the quality of life, and we think there's a benefit to continued maintenance therapy, I continue on lenalidomide-based therapy.